Honorable guests, Dr. Lee, Dr. Leung, Professor Holliday, ladies and gentlemen, welcome to the JoyAge International Symposium 2022. We will now begin the opening event. I'm your MC, Eric Yu. Launched in 2016, the JoyAge was initiated and funded by the Hong Kong Jockey Club Charities Trust, which aims to tackle the problem of geriatric depression, enhance professional and non-professional capacity in mental support, and raise public awareness of geriatric mental health. This is our 6th year running the program, and we have now expanded service delivered to all 18 districts in Hong Kong. Our collaborative step care service model bridges elderly and mental health service at community level, providing a standardized prevention and timely intervention services for at-risk or depressed elderly, and provided them a non-pharmacological option in addition to the regular public mental health services. To further engage and empower the elderly, we have also trained over 3,600 young olds as ambassadors and peer supporters who are knowledgeable about mental health in order to support the older adults in the community. As the annual highlight event of JoyAge, today's International Symposium, kickstarting on the World Mental Health Day, brings together well-renowned speakers to share their insight and experience on the access to treatment for older people with common mental disorders around the world, and to explore further implications for mental health care in primary care setting in Hong Kong. This will be an invaluable platform for knowledge exchange among fellow researchers, frontline practitioners who serve the older adult population and the general public. Let's begin today's program with a welcome message from Dr. Donald Lee, SBS, CSTJ, JP, Chairman of the Elderly Commission, EC.
Gabriel, Professor Holliday, distinguished guests, ladies and gentlemen. Good afternoon. It is my great pleasure to welcome you all to this virtual symposium of the Jockey Club JoyAge project today. The World Health Organization made a visionary declaration that primary care was the key to health for all in Alma Ata 40 years ago. The Declaration of Astana in 2018 reaffirmed this historic 1978 Declaration of Alma Ata, with world leaders committing to primary health care. For the past 30 years, the Hong Kong SAR government has initiated healthcare reforms to enhance primary health care. As President Xi Jinping said during his visit to a mainland healthcare institution last year, health is the most important indicator of people's happiness. Though Hong Kong performed well in many health indicators, having sustained the world's longest life expectancy, almost a decade, the challenges brought by aging population cannot be underestimated. A most recent initiative in Hong Kong will be the strengthening of district-based primary health care services. This is one of the recommendations in the forthcoming primary healthcare blueprint to be released soon, which is formulated by the Steering Committee on the Primary Healthcare Development of the Health Bureau. The establishment of district health centers, or DHC and DHC Express, and the adoption of a multidisciplinary primary care team approach will enable a new model of medical social collaboration and public-private partnerships. The quality of life of our senior citizens is most important. As a family doctor, I know how many elderly patients rely on the general practitioners or family doctors as the point of entry into the healthcare system. This is where I see the great potential of integrating the management of mental health into the primary healthcare system. Managing common mental disorders in the community can alleviate the pressing needs of our citizens and shorten waiting time. I'm indeed honored to have taken up the chairmanship of the Elderly Commission recently. The Elderly Commission applaud the government's initiative to provide more integrated and accessible mental health care for older people. The great success of the rollout of the territory-wide dementia community service schemes at the district elderly community centers and the hospital authorities clusters highlight the need and advantages for medical social collaboration, demonstrating how shifting mental health of older adults with dementia from hospital to community setting is attainable. I'm happy to report that the Advisory Committee of Mental Health under the Health Bureau has planned for more collaboration with Elderly Commission and other stakeholders to enhance the mental health support service for the elderly. I've been the convener of the Advisory Committee of the Jockey Club JoyAge project since the project launched 5 years ago, witnessing its successful scale-up of service from 4 pilot districts to all 18 districts. I applaud the vision of the Hong Kong Jockey Club Charities Trust to initiate this meaningful project that brings together the existing community elderly and mental wellness services. The project provides an excellent platform in promoting elderly mental health, which is highlighted in our symposium today. I would also like to extend my appreciation to the project team at the Hong Kong University for their dedication and great efforts put into this project. Since the 1970s, community-based mental health care under primary care setting has been acknowledged in many places around the world. The discussion and debate are still ongoing and receiving much attention. I'm sure the impressive list of international speakers which Hong Kong University has lined up for this symposium would provide all of you some food for thought and discussion. I'm confident that many of the experts' sharing of their experience and live examples would be highly relevant and inspiring to stakeholders as well as to policy makers. Thank you very much.
Thank you, Dr. Lee. And now a message from our guest of honor, Dr. Gabriel Leung, Executive Director, Charities and Community of the Hong Kong Jockey Club.
Good afternoon. Donald, Ian, distinguished speakers, ladies and gentlemen. Welcome to this online symposium. One of the great triumphs of modern medicine is the increasing number of people who live on into their golden years. Here in Hong Kong, for example, almost 1 in 3 will be 65 or above by 2041. In fact, my own research has shown that Hong Kongers have enjoyed the longest life expectancy at birth globally for 7 years now and counting. At once, however, this enormous success has also brought about its own unique set of challenges. For as populations age, there is not only increasing demand for healthcare, but to treat the varied and many mental wellness issues that often accompany old age. Issues that can lead to increased disability, other morbidities, or even death. Unfortunately, the supply of professionals trained to deal with these needs has not kept pace with demand. In particular, amongst those professions who have most contact with the elderly. They are primary care doctors, residential home staff, and frontline hospital workers. The sad fact is that in Hong Kong today, an older person suffering from a common mental illness may have to wait until 2024 to get a public psychiatric consultation. COVID-19 has undoubtedly exacerbated the problem. Stretched public health services have been unable to cope with the surging demand for mental health care, particularly as the pandemic immediately followed the 2019 social unrest that per se caused a huge spike in mental health burden, thus need for care, as the trust-funded family cohort study findings have demonstrated. Further evidence comes from the surveillance and early warning system for suicide prevention developed by the Hong Kong Jockey Club Centre for Suicide Research and Prevention at the University of Hong Kong. At the height of the 5th wave of COVID-19 in Hong Kong, its suicide risk index reached a crisis level. It was the first time such a warning had been issued. Among all age groups, those aged 65 or above recorded the highest number of suicides. Now, with this background, today's symposium, convened by the JC JoyAge project, could not be more timely. Drawing on the expertise of mental health professionals from across the world, we will explore this fundamental issue. How, given the surge in demand to provide high-quality and person-centered mental health care to older adults in the primary care setting? For those of you unfamiliar with JoyAge, it was initiated by the club's Charities Trust in 2016 together with the University of Hong Kong and NGO partners. It provides community-based mental health support to Hong Kong senior citizens. Employing a cross-sectoral stepped care model, it provides both prevention and intervention services to older adults at risk of or living with depression. A key feature is to build the capacity of social service professionals through standardized mental health training and workshops. Equally important is the deployment of young olds to provide social support and companionship to their older peers, and also to act as a vital frontline in picking up mental health needs amongst their peer networks. I should like to thank all the distinguished speakers for sharing their wisdom and insights today, and our audience, you, for joining us. I hope you will find the symposium informative as well as thought-provoking, and I very much sincerely hope that it will help all of us in our joint effort to build a stronger, healthier community for all.
Thank you, Dr. Leung. Finally, a message from Professor Ian Holliday, Vice President and Pro-Vice-Chancellor, Teaching and Learning of the University of Hong Kong.
Good afternoon. I'm delighted to join you virtually for this international symposium on healthy aging. The aging population is a global challenge. Here in Hong Kong, 20% of our residents are aged 65 and above. The figure is expected to reach over 30% by 2040. Although most older people in Hong Kong live a healthy life, many face chronic physical and mental health challenges. Some also live in socially and economically deprived environments. The COVID-19 pandemic has of course exacerbated these challenges. In our Faculty of Social Sciences and Li Ka-shing Faculty of Medicine, researchers have been developing evidence-based interventions to provide better support to older people and their carers. The university is also setting up a new Geron Technology Research Centre to pursue further cutting-edge research. In our Department of Social Work and Social Administration, master's programs prepare advanced practice professionals in mental health and aging services. JC JoyAge, the Jockey Club Holistic Support Project for Elderly Mental Wellness, was launched in 2016 with generous support from the Hong Kong Jockey Club Charities Trust. In the pilot phase from 2016 to 2019, the project partnered with 6 local NGOs and 8 centres in 4 Hong Kong districts to carry out more than 100,000 outreach and engagement sessions and provide services to 4,000 older people. Over 90% of the service recipients reported improved mental health. Building on this foundation, the Charities Trust supported extension of the Jockey Club JoyAge project. From 2020 to 2021, the project expanded to 12 districts. Since January 22, it has partnered with 17 NGOs and 47 centres across the whole of Hong Kong. During the COVID-19 pandemic, the project team has continued to reach out and serve the local community. 2 large-scale telephone surveys were carried out in 2020 and 2022 to screen for depression risk in older people. More than 13,000 people responded, and the prevalence of those at high risk for depression rose from 8% in 2020 to 14% in 2022, suggesting a growing need for mental health care services. This year's symposium focuses on creating a primary mental health care system for older people with common mental disorders. We invited distinguished speakers to share their experience of providing mental health care in a primary health care setting. We look forward to learning from this wealth of experience, both good and bad, to enhance the local system and better support older people with common mental disorders in Hong Kong. In doing so, we will deepen our partnership with the Hong Kong SAR government, local charities, and community members. On behalf of the University of Hong Kong, I welcome our distinguished overseas speakers and all participants to this symposium. I wish all of you every success.
Thank you, Professor Holliday. This is the end of the opening event. Thank you very much for joining us. We will now take a break until 3:30 p.m. Hong Kong time. After that, we will proceed our keynote presentation hosted by Professor David Clark of the University of Oxford. He will share with us the story behind improving access to psychological therapy, IAPT program, followed by a facilitated discussion and a Q&A session, jointly hosted by Professor Terry Leung. Please stay tuned for the session. Dear guests, welcome back to the JoyAge International Symposium 2022. Before we start, we would like to thank our speakers for their generosity of allowing us to record today's section and make the resources online later. To our audience, you are more than welcome to share recording to your colleagues and fellow researchers, which will be available on our website later. There will also be a Q&A session at the end of today's presentation. Please feel free to send your ideas and thoughts and questions to our speakers by typing in the chat box anytime during the presentation. We will collect these and address them during the Q&A session. We will now begin our session. We are honored to have Professor David Clark from the University of Oxford and Professor Terry Leung from the University of Hong Kong joining us today. Professor David Clark is a professor and chair of experimental psychology from the University of Oxford, as well as the National Clinical and Informatics Advisor for the Improving Access to Psychological Therapy IAPT program in the UK. He is well known for his groundbreaking works on understanding and treating psychological anxiety disorders. Today, he will give a presentation about the story of IAPT program for treating common mental disorders. After that, there will be a facilitated discussion with Professor Terry Leung and a Q&A session to interact with our audience. Let's pass the time to our speaker. Professor Clark, please.
Thank you. And it's a great pleasure to be joining you all today. I'm just going to move on to my slides. Great. Okay, so it's a pleasure to be joining you all today in Hong Kong on what is World Mental Health Day, to be celebrating the achievements that you've been making in the JoyAge project for elderly people in Hong Kong. And I know part of today's meeting is thinking how you will build on that already excellent work and extend it further. And in that context, your organizers were kind enough to invite me to say a little bit about the IAPT program that we've been doing in England to also improve access to psychological therapies. So the IAPT program was created to really deal with an injustice. And the injustice was that clinical guidelines in England, we have a body called NICE, which generates guidelines indicating what's effective as interventions in mental health. And they were recommending evidence-based short-term psychological therapies. That means sort of up to 14 to 20 sessions, but often rather less, as first-line interventions for the common mental health problems, such as depression and all the different anxiety disorders in adults of all ages. And surveys of the public showed that the public would like access to psychological therapies. People were asked, if you had a choice between medication or an evidence-based psychological therapy, what would you prefer? And of course, some people say, well, I prefer the medication. But in a ratio of 3 to 1, people said they would like psychological therapy. But in England, at least, when we started the IAPT program back in 2007, less than 5% of adults were getting an evidence-based psychological therapy for their anxiety or depression. And the waits to start treatment were often over a year. And I think it's fair to say that probably in no country in the world was the public getting what it wanted, in the sense that having evidence-based psychological treatments more widely available than medication. So the IAPT program is an attempt to deal with that, and it involves firstly training a large number, currently about 10,000 psychological therapists, using national evidence-based training curricula, and at the end of the course, checking that they've developed all the competencies needed to deliver the latest psychological therapies by observing their performance on videotapes of sessions with clients, and only passing them if they've shown all the relevant competencies. And then deploying these new staff in stepped care psychological therapy services, new ones for depression and all the anxiety disorders. So our clinical guidelines suggest that for people with mild to moderate depression and many of the anxiety disorders, but not PTSD or social anxiety, many people will benefit from an intervention which is relatively low intensity in terms of the amount of therapist time, something like guided self-help, where people work through self-help materials and then have short, often telephone calls or meetings with a well-being practitioner once a week. Many people seem to benefit from that, but if they don't, the idea is they're stepped up to what we call high-intensity therapy, more conventional therapy, where they're seeing a somewhat more experienced psychological therapist once a week, often in person, but during the pandemic, remotely through video. And for the more severe cases, they would go straight to high-intensity therapy. So that's the step care model. A key feature of this program was to try to measure and report the clinical outcomes of every single patient who receives a course of treatment. So in England, this was a unique exercise in public transparency. Our aim was to get outcome data on everyone who has a course of treatment. And by that, we mean everyone who's had an assessment and has come to at least the first therapy session. So they've had at least 2 sessions. And we wanted to report the outcomes that each of the IAPT services achieves. This is, of course, to help the government see whether or not the services are delivering value for money. It's also to help the services learn from each other, because you'll find some services do better than others, and they can discuss differences in how they're doing things and learn from each other. This is a big program, and in order to persuade the government to go for it, you needed both sound clinical arguments, and they were largely advanced by myself, and also economic arguments, and they were put together by a very distinguished economist, Richard Layard, from the London School of Economics, and we put together a joint argument. You will find the details of the economic argument written out in considerable detail in our book, Thrive, The Power of Psychological Therapies. It's a Penguin book. It's also published in the US in this rather garish red cover, red and yellow cover. And this is the Dutch version as well. But the key point was to say that untreated anxiety and depression cost each of our nations a lot of money. They depress the size of your economy or your gross domestic product by about 4 percentage points. That is partly because people who are in work but have anxiety or depression often have their mind on their worries and are less focused on their work and are less productive at work, and that obviously affects the economy. But also, of course, sadly, many people with anxiety and depression feel that find that they can't carry on working. And of course, the next question is, can you train therapists in big routine services to deliver treatments in the way that they are in the sort of gold standard research studies that generate the clinical guidance? And we had some evidence of doing that when my team was asked to train some therapists in a town in Northern Ireland following a large terrorist bomb, the Omar bomb. This is, it was a car bomb, and this was the picture of the emergency services clearing up after the devastation of that event. And many people develop post-traumatic stress disorder in the community. We opened a service to treat everyone with post-traumatic stress disorder in the community, trained existing therapists to do it, and found that we got clinical outcomes as good as in gold standard randomized controlled trials. Another key question was, of course, can we actually manage to monitor the outcomes of everyone to see whether in this new initiative people will get the results we expect? And we found that the way to do that is to get people to fill in a short measure of anxiety and depression each time they're seen. So a session by session outcome monitoring system. This means that even if someone stops therapy earlier than you anticipate, you always have a clinical endpoint, so you can get almost complete data. And crucially for the government, the key thing was we calculated that the cost of this program, the overall net cost will be essentially nothing, because it saves more money than it costs. And the savings come in 2 points. One that is very relevant to an older age population is big savings to the cost of physical healthcare. So we find that people with anxiety and depression often require much more physical health care, much more investigations one way or another, and also managing any long-term conditions, health conditions that they have, is more expensive if they're depressed or anxious. And research studies showed that if you help people to recover from their anxiety and depression, these other healthcare costs are much reduced. And in fact, so much so that that alone would cover the cost of the psychological therapy. In addition, of course, for those people who are in the working age population, then we also find that psychological therapy helps them get back into work, or if they are at work, be more focused in work. And so that again saves the nation a considerable amount of money. So that's the background. The program was initially launched in a small way in 2005 with a couple of pilot sites. And there was a lot of lobbying where academics got together with charities to argue the case for the government, and the government did listen. This is me giving a copy of Thrive to the Prime Minister, David Cameron, and successive governments across the whole spectrum have supported the initiative. And as it has been shown to be successful, it has been gradually expanded year on year. When it was first announced, the government saw it as a groundbreaking service. They promised that waiting times would be reduced from over a year to just a few weeks to start treatment. And they also said, if we look at the research studies, what you find in gold standard randomized controlled trials is about 50% of people with anxiety and depression will fully recover at the end of a course of treatment. And then about 70% or so will show substantial improvements. And so there was a promise that as the services mature, they would get those sort of outcomes. So what has happened so far? Well, the national rollout started in 2008. So we're now well into the program, 14 years on. It started small, but we now see well over 1 million people every year in the services. Not everyone requires a course of psychological treatment. Some people just need some brief advice, or in fact, it turns out from the assessment their problem isn't anxiety, or depression, and they need some treatment in some other service. But currently, round about 660,000 people each year have a course of psychological therapy, and the waiting time to get started has reduced enormously. It is now just a few weeks, on average 20 days. And using this session-by-session outcome monitoring system, we are able to collect pre- and post-treatment measures of how severe your anxiety and your depression is, and also how much it interferes with your life in 99% of that 660,000 people. So almost complete data. And we are finding that currently the clinical outcomes are now broadly in line with what you'd expect from all the research studies. And you see how the clinical outcomes have changed over time in this graph here. So the red line is that sort of government target of 50% of people recovering. And the solid blue line is the actual figures year on year. And you can see that right at the start of the program, we didn't achieve those ambitious goals. But even though we were training therapists appropriately, but as time went on, we've steadily improved. And for the last 6 years, we've been above that target value very consistently. You'll also see that the people who've shown substantial improvement is now very close to that 70% figure that we were targeting. So the program—
I didn't catch that. Could you try again?
So the program has achieved the outcomes that were intended, but it's taken a while to get there. And what it has helped us get there is really collecting the data from everyone, because that has allowed us to discover that some services get better outcomes than others. We do better with some patient groups than others. And we've learned from that experience, worked out what are the ingredients of those services that do particularly well, and have fed that information back into the system. And I'd like to really show you some of the things we've discovered from this, because to me, who is really a researcher who spent most of my life trying to develop new psychological therapies, this has been an extraordinary experience, because I've discovered, along with many other people involved in IAPT, that it's not just the psychological therapy that's important in terms of getting good outcomes, it's how you put it all together in a clinical service. And that feature is just as important as the particular therapy you use. So the data is really what's helped us get these very good outcomes. So I should say a little bit about this session-by-session outcome monitoring system. Because when we started the IAPT program, many people said, well, do you really need to take a measure each time you see people? If you just give a measure at the beginning and end of treatment, you won't get data from everyone, but maybe that doesn't matter. Maybe it's just sort of chance that you haven't been getting post-treatment data. And before IAPT, there wasn't a national audit of all psychological therapies in the country, and that showed that we were only getting outcome data on 38% of people who had a course of psychological therapy. We got questionnaires on most people who started treatment, but often we missed the one at the end of treatment when we were just trying to give the questionnaire at the beginning and end. So in a pilot project for IAPT, we decided to test out, does it really matter? Do you get different results if you get data from everyone? And so this graph shows that pilot project. What we did is, for everyone in a pilot service, we did give them a simple measure of depression and anxiety each session. So we did get data on all of them. But we also gave them another measure in the conventional way, just at the beginning and end of treatment. And not surprisingly, for that measure, we only got 50% of people giving you post-treatment data. So, and it was largely because the last measure, the post-treatment one, was missing. But of course, we know how much they've improved because we had the session-by-session measures. So this graph shows you the results. So for those people who normally you don't get the post-treatment data, they have actually only improved about 40% as much as those people who you normally would get the post-treatment data. So this really told us and the government that we are deluding ourselves about how good our clinical services are unless we get outcome data on everyone. And that's because when you don't get data, it tends to be the people who've done less well who fail to give you the data. So this was a very important finding, and it meant that the government really insisted that we do collect data from everyone so we get a fair understanding of what is happening in our services. You saw the sort of clinical outcomes on measures of anxiety and depression, but it's obviously also very important that patients are satisfied with their service. And so they're given measures of satisfaction at the end of their assessment and also at the end of treatment. And this slide here shows that in general, the satisfaction levels are very high. People are in general completely or mostly satisfied with their assessment. They do think that people help them understand and address their difficulties, and they do feel in most cases that they got the help that mattered to them. Now, of course, JoyAge is a project that's specifically for older age people, and so I have looked for today's presentation at the outcomes in IAPT broken down by age. And the good news is that these psychological therapies actually perform best of all in older people. So you can see this is our youngest age group. The national recovery rate is 44%, 64% show what we call reliable or substantial improvement. And that as you get a little bit older, then the rate gets to our target of 52%. But for those people who are over 65, you can see the recovery rate is over 60%, and the reliable improvement rates are somewhat larger as well. So for those older people who we see in the services, the outcomes are very good indeed. However, I think it's fair to say that at the moment, older people are underrepresented in the services. So they represent about 7% of people seen in the services. So we are currently working on outreach to make more older people aware of the services and bring them in because we think we can help them a lot. So what are the sort of treatments that are offered? Well, the low intensity treatments are things like guided self-help, computerized CBT. The high intensity treatments, NICE only recommends various forms of cognitive behavior therapy for the anxiety disorders, so that's what we deliver. But for depression, NICE actually recommends several different psychological treatments, and we try to give patients a choice in the treatment of depression between CBT, but also counseling, couples therapy if people are depressed in the context of a relationship issue and their partner's willing to work with them, interpersonal psychotherapy, and brief psychodynamic psychotherapy. And for PTSD, also eye movement desensitization reprocessing. And this is a sort of chart which shows you, we have 209 IAPT services, and CBT is available in all of them. In most of them also counseling, so patients are in almost all services getting a choice. But you can see the other therapies are not quite so widely available at the moment, but we're addressing that. So I said that we'd learned a lot from the data and fed that learning back to the services to help them improve their outcomes. In a short keynote such as this, I can't cover all the things we have learned, but you will find most of them in a free manual, which you can download from this website, www.england.nhs.uk, which summarizes the main findings. This sort of graph here shows you how things have progressed. So here, this is a 5-year period, and you can see from the dotted line, this is the average recovery rate for all services, starting at 45% and then well above 50%. But what I'd like to draw your attention to is these two green lines. So this one here is the bottom 10% of services in terms of outcomes. So those who in 2015 were in the bottom 10% for the outcomes that they achieved. And you can see they have improved very considerably. The ones that were in the top 10% of their outcomes, they have also improved, but less so. They've just stayed good. The consequence of this is that we have greatly reduced the variability in outcomes between the best and the worst performing services from about 20 percentage points to only 10 percentage points. So what are some of the things that we've learned? Well, an early finding is that it is important to follow clinical guidelines when delivering therapies. So early in the program, we did have quite a few instances where therapists, very experienced therapists, felt they didn't need to follow the clinical guidelines and might give another treatment. For example, NICE recommends cognitive behavior therapy and counseling for depression. And we found that we got the same outcome with those two treatments in depression. But NICE does not recommend counseling for generalized anxiety disorder, but quite a lot of counselors treated generalized anxiety disorder in the early days of the program. And what we found was that many people did get better with counseling. It was about 48%. But what the counselors didn't know is that those patients who had cognitive behavior therapy, 58% of them recovered. So it does matter that you follow the clinical guidelines. And now, in general, the services follow the clinical guidelines quite closely because of that discovery. But also, how the service is organized is important. And this was first revealed in a paper that we published in Lancet in 2018, where we compared the outcomes that different services achieved, looking at various organizational features of the services. The first one was that services varied in how consistent they were at identifying what we call a problem descriptor, or the diagnosis of the patient. And identifying, I'm mainly focusing on treating depression, or I'm mainly focusing on treating obsessive compulsive disorder or PTSD. Those services who were clear in their assessment on this got overall better outcomes. How long you wait to start therapy was also important. And you see that on this graph here, where we've plotted each blue dot is all the outcomes of all patients who were treated in an IAPT service in 1 year. So each blue dot represents about 5,000 patients. And we've plotted the mean number of days that people would have to wait before starting treatment in that particular service, and then the probability that people will show reliable improvement in that service once they've finished treatment. And you can see that it doesn't really matter how long you wait for the first 6 weeks, you get very good outcomes. But if you're in a service which in general gets people to wait longer than 6 weeks before treatment, then the outcomes get less good, even though the treatments that are being offered are the same. So it seems that there's a window of opportunity that one needs to utilize to get going on psychological therapy. Also, we found that those services that used the step care system well, so those services who, if someone didn't respond to a low intensity intervention, promptly stepped them up to high intensity, got better outcomes. And also, just like in medication, there was a dose response effect. Those services that have overall a slightly higher average number of sessions get better outcomes. But the average number that was associated with optimal outcomes was not very high. It was about 10, but currently we offer on average about 8, so we can see more improvement. Another finding was that if you look at the different areas of the country where the IAPT services are, we did find that those services that were in the more socially deprived areas of the country did get less good outcomes. However, we did find that this effect of social deprivation on outcomes is very much reduced if you statistically control for these quality factors. So our broad conclusion was you can get very good outcomes in socially deprived areas as long as you make sure you have a good quality IAPT service in those areas. So you need the right treatment and the right type of service. And I'll show you a little bit more about what we've got from the data. So early on in the program, so back in 2015, we did notice that we had rather different outcomes for people from different ethnic groups in the community. So we were getting better outcomes from the white population than the Black population or the Asian population. But we've studied that in great detail. We were working out what was holding people back from engaging in psychological therapies from different ethnic groups. And we developed a special positive practice guideline, which was published on the basis of those findings. And as you can see, things have really improved enormously. So now we find there is no difference in outcome between the white and Black population, and the difference to the Asian population has much reduced. And of course, you can see all the outcomes have improved over time. Going back to this effect of social deprivation, remember I was saying that we can get really good outcomes in socially deprived areas as long as we ensure that they have a good quality IAPT service. And this slide here rather nicely illustrates that fact. So what I've chosen is 2 areas in England which are next to each other. One, Windsor, many of you might have noticed from the television, is where our Queen, who's just died, and our new King live, Windsor Castle. And that is not a socially deprived area of the country. It is only the 4th percentile in terms of social deprivation. But next to it is an area called Slough, which is at one of the most socially deprived areas in the south of England. So it's 68th percentile for social deprivation. But the key thing is that both areas are served by a single high quality IAPT service. And you can see that in fact, there is really no difference in outcomes. They're both performing better than the average. And if anything, there's a small difference in favor of the service in the more deprived area in Slough. So if our new King, King Charles, felt that he might like to use an IAPT service, we might almost suggest that he should ask the chauffeur to drive him to Slough for treatment. And this graph here also illustrates something very important about social deprivation. So you've seen from our graphs that our outcomes have been improving steadily over the years. And what I've plotted here is the amount of improvement in outcomes that you've got between 2016 and 2019, which is when we had quite complete data, as a function of the social deprivation of the area where the service is. And you can see that we're getting our biggest improvements in outcome in the more socially deprived areas. So I'd now like to move on to another development in IAPT, which is, I think, very relevant to the older age population. So in England, in the community, about 40% of people who have depression and or an anxiety disorder also have a long-term physical health condition, such as diabetes, chronic obstructive pulmonary disease, cardiovascular problems. And in England, their mental and physical health care is rarely coordinated. If they have someone looking after their diabetes, say, that'll be in a clinic in one part of the city or in one area, the rural community. And if they're also being seen in an IAPT service, at least until recently, that would be somewhere completely different. And
I didn't catch that.
And if,
Could you try?
And if they manage to go to their appointments for both, the one thing you could guarantee is that the people who are looking after their physical health care would not be closely coordinating with those people who were looking after their mental health care. So this is not right. It's a single person, and we should be treating them holistically. We should try and bring together the mental and physical health care. And so that has been one of the ideas in the most recent developments of the IAPT program, where we have created what we call integrated IAPT services, where we bring together in the same clinical pathway mental and physical health care. You would see your IAPT therapist in your diabetes clinic or your cardiovascular clinic, for example. We piloted this in a small number of IAPT services, and we found that these services got very good clinical outcomes, but we also demonstrated that they saved the healthcare system money, because it reduced the cost of managing the diabetes. It reduced the cost of cardiovascular problems. For example, someone who's had a heart attack and then is having cardiac rehabilitation, where they have to develop some graded exercise program, they might not do the cardiac rehabilitation because they're too depressed, or because as they start to exercise, they have panic attacks and think they're dying again. But bringing in the psychological therapist to work with the cardiac nurses allowed us to ensure that people did go fully through their cardiac rehabilitation and get better outcomes, and also are less likely to be turning up in emergency rooms worrying about cardiac problems in the future. So those pilot studies then led to a phased national rollout of the IAPT integrated services starting in 2018. And we now have those services available in approximately 75% of all areas. So we're not finished yet. And obviously, you would expect the people with long-term conditions perhaps to have slightly less good outcomes in terms of their anxiety and depression. And that is what we find, but the difference is really quite small. 48% recovery for those people with long-term conditions and 53% for those without long-term conditions. But interestingly, there's two things about that. Firstly, this difference is partly to do with the fact that the people with the long-term physical health conditions also tend to have more severe anxiety and depression. And when you statistically control for that, this difference in outcomes gets much smaller. Also, very interestingly, the difference in outcomes between people with and without long-term conditions is very small indeed in the older age population. It's really only in the younger age population that we get this effect. So it does seem for older age people, bringing together their physical and mental health care in this way is really helpful. And it means that they can still recover from their anxiety and depression, even with long-term physical health conditions. This is an example of some of the sort of research that's been done as we roll out the program, which really helps the government have greater confidence in the program and invest more. So this is a study that we conducted in the area around Oxford, where I'm based, where we started these IAPT LTC services at different time points. In some areas, we started them earlier than others, and we could use that point as a research design, what you call a stepped wedge design, where you look at the outcomes in the areas where you start the service early and compare them with outcomes in the areas where you haven't started the integrated service. And what we found was that where we start the IAPT long-term conditions services, that greatly reduced the cost of secondary healthcare costs, so outpatient appointments for physical health, and it reduced it by about £360 in the first 3 months treatment. This is about half the cost of the whole psychological therapy, so very significant. We also found for those people who were unemployed but were of the working age population, then this intervention helped them get back into work, or more precisely, those people who were in the control areas were more likely to drop out of work, whereas those in the place where we developed the IAPT system were more likely to get back into work. And these findings have been recently confirmed in a national audit as well. The beauty of this, of course, is that as we have already got the IAPT services in place before the pandemic, it means that we are now using them to help people who have become depressed or anxious in the context of long COVID symptoms, which is really a great asset. So that really brings me on to the pandemic, and you will not be surprised to learn that IAPT was not included in anyone's pandemic planning. But as the nation locked down, it was clear that we couldn't carry on delivering face-to-face psychological therapy. So in a short period of time, about 3 weeks, we issued all the psychological therapists with laptops, and they delivered the therapy remotely, sometimes by phone, often by video link, just as we're doing now. My own research team in Oxford actually stopped the research it was doing for 3 months and just focused on training IAPT therapists in how to do remote therapy. And we did this with large webinars with up to 1,900 attendees at a time. This was taking us into uncharted territory. We didn't know what the therapies would do delivered remotely. But of course, we have this very rich data set in IAPT, which allows us to learn. And firstly, this is the data in terms of the way delivery changed. So this is just before our first lockdown in February 2020. And you can see the blue line is face-to-face therapy. 64% of people were having face-to-face therapy. But once we locked down, the figures got very small indeed, down to just 3% of people having face-to-face therapy. The biggest increase was the use of video, like we're doing right now, which went up by 1,000%. But also the low intensity work was often delivered with telephone support, and that also increased substantially. So that's how we adapted to delivering treatment. But what about the outcomes? Well, firstly, to say, if you're interested in anything to do with how we do the therapy remotely, could I mention to you, there is a free therapist resources website, www.oxcadatresources.com. This is the website from my team. You're very welcome to log in, and you can see there's a COVID-19 page which shows you the webinars we have on how to do remote treatment, lots of written guides about how to do it as well, and lots of other information about how to treat PTSD, panic disorder, social anxiety with CBT. You do need to register for the website, and do register as a clinician, because that gives you access to all the video materials. But it is completely free, and you're very welcome to use it in any way that you find helpful for your work. So what about the outcomes during the pandemic? So here we have the sort of recovery rates and the reliable improvement rates in the 3 months up to the lockdown. We then locked down, and there is a bit of a drop in recovery rates and improvement rates for the first 2 months as we're adapting to remote delivery. But you can see very quickly after that, we're doing just as well as before, but delivering the therapy very differently. And we are treating just as many people in the pandemic as we were before. So we have learned that video delivery of therapy can work very well, and this will become more a feature of the services going forward. But we have found that for some patients it doesn't work at all. Maybe they don't have the IT skills to do that. Some people, where they live, doesn't feel secure for psychological therapy. They may not have a room of their own that they can receive the psychological therapy. They may be worried that other people might overhear what is said, and they would feel that threatened by that. And quite a lot of patients who did well with remote delivery say, but if I was to come back again, I would prefer face-to-face therapy if it's available. So it's a mixed picture from a patient's point of view. From a therapist's point of view, there are many positives. Therapists found it was more flexible work style to be able to work partly from home, and they could be more flexible about the hours that they did the work, particularly if they have childcare duties. But they miss some of the support they might get from colleagues of being in a clinic together and the social interactions of that. So what we have decided is that in the future, remote delivery will be an option offered to patients, but it will be a patient choice. And to make sure it's a real choice, we will be carefully monitoring how long it takes before you start treatment in each service, whether you have face-to-face therapy or remote therapy. And we will be requiring the services to organize their workforce so that you don't have to wait any longer for face-to-face therapy than remote therapy, because then it is a genuine patient choice. So that's sort of where we're up to so far. I'd like to just wind up by saying, well, is that as good as you can get, or can we still improve in the outcomes that we achieve? And I think we can. So this is the graph I showed you earlier on of the sort of steady progress in terms of the clinical outcomes we achieve in the IAPT services. But for the last 6 years or so, you can say we've sort of plateaued, haven't we? We've been above the government target, but not much. But that's what a lot of the research studies show. So you might say, that's it. But there are elements in our data which suggest we can do better still. So this, for example, shows you the mean number of sessions patients have during their course of treatment, and the number of patients who had that number of sessions. And this is really data from the last 1 million patients that we treated in IAPT. And you can see that the average now is 8 sessions. And you can see there's lots of people who have somewhat less than that, 2, 3, 4, 5, 6, 7. And then there are people who have up to into the high 20s, but it's a much smaller number. So you might ask, has the system found the sort of adapted to the optimal level of delivery? Is this really the best, in the sense that most people who don't recover with the smaller number of sessions, maybe they don't have a chance to recover with these extra sessions, so maybe it's not a good use of clinician time? Or maybe it's the opposite. Maybe we should be offering people who haven't recovered with the lower number of sessions some more if they're showing improvement, and they would benefit. Well, the next graph shows that it's probably the latter. So here we find the probability of recovering or showing reliable improvement as a function of how many sessions you've had. So the first thing to say is, if you just had 2 sessions, your recovery rates are pretty low. That's not surprising, because the measures are given at the beginning of each session. And so someone who's only had 2 sessions really has only had an assessment, and then the outcomes monitored a week later. As you increase the number of sessions, you rapidly get to sort of really good outcomes by 5, 6, 7 sessions. And you're hitting that sort of high level for improvement rates as well by 7 to 8. But look what happens if you haven't recovered at that point and we give you some more sessions. And you can see it's still the case that many people will recover if you give them a few more sessions. And so we are now planning to follow that early research finding that I mentioned in the Lancet and increase the capacity of the services so that they can give some people who don't respond at the lower levels somewhat more sessions. We think on average we'll move from about 8 sessions on average to about 10 sessions on average, but obviously people who respond quicker get less sessions. And we are pretty confident that is going to help us further improve our overall outcomes. I should also say that one of the beauties of collecting a very large amount of data is it allows you to focus in much more detail on trying to identify those people who do less well and those people who do better. And once you can identify their characteristics, of course, you can work to improve your services for those people who don't do so well. And so here's an illustration of that. We did a study of Rob Sanders in London, analyzed a very large set of IAPT data in 2016, and found that there was a particular group of people who had a certain set of personal and clinical characteristics who tended to do really rather poorly in IAPT. So their recovery rate was about 20%. These are people who had what he called, in a very technical sense, the latent profile 7, LP7. If you look at the characteristics of these people, they are people who score very high on depression and anxiety at the start of treatment. They also tend to be on welfare benefits. They tend to be unemployed or partly employed, and rather surprisingly, they also have some phobias. So now that we've identified that group of people, the IAPT services around Oxford, where I live, and I direct the network there, have got the clinical algorithm, which allows you to identify people with latent profile 7. And we identify everyone with that profile at the start of treatment. And we offer those people not just the psychological therapy, but also the assistance of an employment advisor, which will help them stay in work if they're struggling with work, or get back into work if they're out of work. Not everyone accepts that offer, but many do. And we have found that among those people who accept the offer, so combine the psychological therapy with the employment advice, the recovery rate is 47%, much better than if they didn't have the employment advisor. So here's a group of people that our data showed, not just from a diagnosis, but from a complex pattern of things happening in their lives, they tend not to do so well. But once you've discovered that, we worked out a way of really getting good outcomes for them. And I think you'll find you can do the same sort of thing with older age populations once you have lots of data. So finally, what are the sort of future developments we're planning for IAPT? Well, I think one of them is, of course, to make greater use of one of the big advances in psychotherapy research in recent years, which is internet-based therapies, where in psychological therapies, you're really teaching people skills to use to manage their emotional difficulties. And of course, sitting in a room with a therapist talking to them or talking on the phone isn't the only way of learning new skills. You could obviously put a lot of the learning into an online program that people could access from their home 24 hours a day, and then have your therapists supporting people through that sort of self-study with messaging and short video calls or phone calls. Potentially, that has a big advantage that it might reduce the amount of therapist time and so enable you to see many more patients. It also, for some patients, of course, has the advantage that they can work on the therapy at any time that fits in with their busy lives, and they don't have to travel to clinics. Also, of course, the content of the therapy can be very consistent. So my group has been developing an internet version of cognitive therapy for social anxiety disorder. That's the leading NICE recommended treatment for social anxiety. And this is the results from a recent trial that was published in Psychological Medicine. And here we plot the severity of people's social anxiety. And this is a group of people who had the standard face-to-face therapy seen once a week by a therapist. And this is the increasing amount of therapist time as you go through treatment. And the total amount of therapist time is 18 hours. But you can see it's well spent. Each extra hour of therapy gives a bit further improvement on average, but it's a lot of time. If, however, you allocate people randomly to the internet program instead, with much shorter sessions with the therapist and support, and they're remote, they're not in face-to-face, you can see you get the same good outcomes in much less therapist time. In fact, just over 6 hours. And the recovery rates are excellent. In fact, they're better than we normally get in IAPT. So in our randomized control trial, 63% of people recovered and 84% were reliably improved with research therapists. But recently, we've also deployed it in IAPT services with routine therapists, and you can see you get almost identical outcomes. So one of the nice things about the internet treatments is that the delivery of the content is very consistent. And this is further illustrated by a project that we've been really delighted to be involved with the clinicians, particularly led by Patrick Leung in the Chinese University of Hong Kong, where they have also done a randomized controlled trial of our treatment and have found they get equally excellent results in Hong Kong. Of course, you know, it's not just reduction in symptoms that you're aiming for here. You really want people to feel that they're living a life that they want to live, freed from their mental health problems. So one of the questions we now ask people is, but at the end of therapy, are you more able to live the life that you'd like to live, or less able now you've had treatment? And really encouraging, we found that 91% of patients said that they are more able to live the life that they would like to live, having had the internet treatment. So I think these treatments, and of course there are other groups developing them, will become more part of IAPT as time progresses, but again, as a patient choice. So people could choose between these and face-to-face therapy. We're also starting to explore bringing in virtual reality treatments, particularly for people with phobias, like height phobias and things like that, who are often too scared to engage in real life exposure to the things they're afraid of initially in therapy. And also it's difficult to organize clinically because the therapist has to leave the office to accompany the patient. But we're finding we can do really quite well by giving people experience with the stimuli that they are frightened about, like being on heights or small animals, in a virtual world. And we can reduce people's fears greatly in the virtual world, but we then find it transfers very well to the real world. So that's really covered an overview of the IAPT program. It is an English program, but I'm pleased to say that it is attracting attention elsewhere in the world. Nature, the science journal, kindly describes it in a editorial as world-beating. The Americans have seen it as the most ambitious effort to treat depression, anxiety, and common mental health problems. And it is stimulating similar developments in other countries. In Norway, they have a version of IAPT, which is now in 60 different areas. In Ontario, in Canada, they have a program almost identical to IAPT called Structured Psychotherapy. In Australia, they have a program called New Access based on IAPT. And in Israel, they're running a national pilot of the IAPT system. And Finland has just announced an IAPT service called Therapies to the front lines. And of course, I know that in Hong Kong, you are developing your own step care services in many settings. And I know the Jockey Club has been strongly supporting that, which is really exciting. So finally, some lessons from the IAPT service, at least lessons that I feel I have learned in doing this. I think it is really very important for us in each of our countries to have clinical guidelines which indicate what are the treatments that have the strongest evidence base, and to try and follow those. That has really been an important lesson in IAPT. You really do get better outcomes with the evidence-based treatments. Collecting outcome data on everyone has been incredibly important for us. I think if we hadn't done that, we would still be at sort of, say, 40% recovery rates. Even now, 14 years on, we wouldn't have known that that was the case. We'd have been ignorant of it. But having the data allowed us to get much better outcomes, and it means that over 100,000 patients every year are more likely to improve because we've learned from the data than they would have done if we just carried on with the service the way we started. Every country is short of money, and it's very important to pay attention to the economics of delivering these therapies. But in general, we've found that they are very economical. They do, in general, save society money. But only, of course, if you deliver the treatments well and people get better. In order to achieve that, we've found that it really helps to have a national training program and national standards for the psychological therapies. In order to get the outcome data, you need to make it easy to collect and use. So we have IT systems that support outcome monitoring. People can just input the questionnaire data on their phone. You don't waste any therapy time collecting outcome data. And you have the system which will plot graphs of progress that the patients can see, the therapists can see, and they can also see in supervision. But it hasn't proved expensive to develop IT systems that support that. On average, it costs us about £3 per patient. Of course, once you've got data, it's very important that it's used in a sensitive way in services. So we find that the quality of the clinical leadership in each IAPT service is crucial. You need leaders who, when they look at the data and they see that maybe the service isn't doing quite as well as they would like in some areas, that they don't take a sort of critical approach to their team and sort of bully them into trying to get better outcomes, but rather the whole team works together, seeing this as an opportunity to innovate and test things out. And so you need to create an innovation environment. But once you do that, the data really helps enormously. So that's really come to the end of my presentation. I hope it's been of some interest. As I say, I have been collaborating with colleagues in Hong Kong. I know you're doing very innovative things, and it's just been an enormous pleasure to share this session with you.
For such an inspiring presentation. And I'm sorry that I don't have time to greet you, to say hi before your talk. And from in your talk, I really appreciate the fact that the first one is a combination between the clinical case and the economic case, so that the government will make it as a policy priority, for the UK. But another one is you also make a statement that it is not only the effectiveness of the intervention, but it is on how to put it in a clinical setting that make a difference. I think this is another lesson that I think in academic we need to learn, because I think we focus a lot on the effectiveness of an intervention, but we did not focus enough on how to put it in a clinical setting that make a difference. Another one is I really appreciate the patients, you, the research team, as well as the government put into the program, in the sense that you allow time for the program, the effectiveness of the program show from lower than 40%, slowly go up to higher than the national benchmark. I think that is another one I think we need to learn, because a lot of time when government or policymakers they look into a new program, they want to see the effectiveness right away without the patient to really slow down and learn from the implementation. So we have some questions, we see from the Q&A session. The first one actually is from our common friend, Dr. Gabriel. Gabriel is not, she is also a co-director of this program, but she is in Australia now for an exchange program. She asked, how did IAPT manage to have enough trained therapists to deliver various psychotherapy based on, personal choice? Particularly, we know that it is extremely expensive and time-consuming to train a professional therapist. So would you please share a little bit on the decision the IAPT team make in terms of selecting who can become the psychotherapist?
Yes, thank you for that question. And of course, it's a very important one. The first thing to say is that the reason why the scale of the IAPT program has only gradually grown each year is because there's a limited number of people that you can train as therapists each year. So the expansion of the program has been largely determined by how many new people we can train each year. In order to make sure that we train as many as possible, we have made the initiative a multi-professional one. So the high-intensity therapists, for example, are not just clinical psychologists. They're also people who had a background in mental health nursing, in social work, and occupational therapy. So, but they go on a course, a training course, which lasts a year, but it's an in-service course. So what happens is that you have training, clinical training in the university 2 days a week. And for the other 3 days a week, you are already working in an IAPT service, seeing patients with the exact problems that you're being trained to treat. And we find that is a very effective way of doing training, because if you try and train people, but they're not working in the service, then a lot of their routine practice is not with the right problems. And so they don't learn so quickly. So our trainees, when they start training, they get a new job. They get a job as working in an IAPT service. And so I think that speeds up the training a lot and gets you to good levels in that 1 year. But of course, they are also doing valuable clinical work in that period, and they're getting supervision in the services. The high-intensity therapists are people who've got some prior experience in mental health. But the low-intensity therapists, we call them the psychological well-being practitioners, they tend to be younger, less experienced people. Mostly, they are recent psychology graduates, undergraduates, who may have done a little bit of voluntary work in mental health, but haven't really become mental health practitioners yet. And we train them again over a year. This time it's a day a week in the university and 4 days a week in the service, practicing the skills. And we found that that works very well. So this is much shorter than the training you do for, say, a clinical psychologist.
Exactly. So do you have for example, a contract with university that provide the IAPT training?
Yes, we do. So we publish a training curriculum for both the psychological well-being practitioners and the high-intensity CBT practitioners, but also actually the high-intensity counselors and the high-intensity couples therapists and the high-intensity brief psychodynamic therapists. And we commission universities to deliver those curricula. And we look very closely at their delivery, and we have professional bodies that will accredit the courses.
Okay, yeah.
So the courses are inspected and are accredited. So for the psychological well-being practitioners, the accreditation is by the British Psychological Society, who visit the courses each year, look at what they're teaching, check that it fits with the curriculum, interview the students, look at the examining. For the high-intensity CBT therapists, it's the British Association of Behavioral and Cognitive Psychotherapy, BABCP, who does the same job. I think this is really important because it's a guarantee of quality.
So another one is, for the success of a clinical program, the integrity or the fidelity of implementation is extremely important. So how do you guarantee, the IAPT participants are really deliver the evidence-based intervention they are trained for? So do you have a mechanism for this kind of, quality assurance?
Yeah, so I think our main mechanism is the quality of the training. In a research study, you'd videotape the sessions and you get people to rate the sessions for competence and fidelity. But in a massive clinical service where you're treating 660,000 people a year, you can't really do that. That would be very expensive. However, we do insist that all the therapists have weekly supervision of their clinical cases. And that's very important. And that's true, for all the fully qualified therapists as well. And so the supervision is a way of checking that people are getting the right therapy, but also, of course, giving the therapist a chance to reflect on if this patient is not improving, how might we adjust the therapy? So I think ongoing clinical supervision is very important. And we call it outcome-informed clinical supervision, because the supervisor and the patient and the therapist always see the graphs of progress at the start of the supervision, and they can look at, what was it you did last week, which has produced that big improvement, and how can we build on that with the rest of therapy? Or we've been trying to do this thing the last few weeks. It's logical, it's what you'd expect, but it's not really working. What should we try different? So I think that's a very important component, and it's time well spent. So each therapist should have an hour a week of supervision, and over a period of a few weeks, they should be able to discuss all of their cases.
I'm just curious, since the program has been implemented for more than a decade, so for people who join therapists who joined the program earlier, so did they move on, for example, later to want to be trained as a CP, a social worker, or they still, see more of a career by itself?
Yes, well, this is a very good question. So we find that among those people who are initially employed as psychological well-being practitioners, they tend to be very keen to have career progression. Their most common progression is actually to be trained as high-intensity therapists. Some of them also go off into clinical psychology training, but most of them stay in mental health. But I think this is making us think a little bit, because at the start of the program, we had the idea we'd train two different workforces, the psychological well-being practitioners who are paid less experienced than the high-intensity therapists. That seemed a good economic argument. But of course, people are ambitious, and it turns out, they want to progress. And that means that we have to keep on training lots of people for the low-intensity work. And in particular, of course, we're finding now that we've got a lot of people who we trained as psychological well-being practitioners or low-intensity therapists. They're now trained as high-intensity therapists. And when they're a high-intensity therapist, they're not using the low-intensity skills. And this seems silly. So we're now, I think, starting to look at what we call blended therapy, where the same therapist, because they've now got both sets of skills, might start someone off on the low-intensity therapy, but if there's a need to do some sessions of high-intensity therapy, they'll shift into that. They may then carry on with the low-intensity. But I think this may work very well in the future, because it means the patient has the same therapist throughout the step care model, and it can be deployed more flexibly. But we are piloting that to find the most cost-effective way of doing that.
So they can still have a career actually within the IAPT program. Wonderful. I have a question from a WhatsApp group. What the person asked is, I appreciate the IAPT long-term conditions in how it addresses both mental and physical health. Were there any challenges in the collaboration between mental and physical health professions, and how those challenges were being resolved?
Yes, well, there were lots of challenges, I'm sure you would guess. And the general approach we've taken to the IAPT program, it is quite radical in many ways. The idea that, therapists record outcomes from everyone and it's publicly reported, some therapists found quite challenging. And so we don't try and transform the whole of the mental health system to work this new way. We've created these new services, and we say, if you're interested in working that way, then opt in to the revolution rather than forcing people into it. And so we've used the same principle in developing the IAPT LTC services. So the local IAPT services have reached out to physicians in different long-term condition pathways, diabetes, cardiovascular disease, have said, we would like to work together with you. This is what we think we can offer. You could give us some suggestions of how we would fit into your pathway. And different areas have developed different initial links depending on where the enthusiasm is. So in some areas, it was much more a diabetes pathway that they started with. In others, it was a cardiac rehabilitation one. And I think that worked best because then you found you're always working with physicians who are interested in mental health. But of course, what happens is that those physicians get pleased that they've got the IAPT LTC service. And when they're having lunch in the hospital with other physicians, they say, well, you know, this is working well for me. And then the other physicians who maybe weren't interested initially say, oh, well, can we do that in our pathway? So it builds enthusiasm that way.
Okay, but I just wonder, in case, for example, if both sides, the specialist, physician, or even the IAPT program staff, they believe the client can also benefit from some drug treatment. So will that be delivered by GP, or do you need to refer them back to specialist mental health or psychiatry to get drug treatment? So how would the combination between psychotherapy, drug treatment, and the long-term condition kind of work together?
Yes. Good. That's another excellent question. So quite a lot of people in IAPT are on medication. They were put on it by their family doctor. And we don't ask them to stop that when they start psychological treatment, because we might get rebound effects. But towards the end of treatment, we, of course, encourage them to withdraw if they want to, and that works well. But mostly the medication management is done in collaboration with the family doctor.
Okay.
So the IAPT therapists liaise with the family doctors. The IAPT therapists do not prescribe themselves.
Okay.
But if it's thought that medication will be helpful, they talk with the family doctor and they agree together. Occasionally, we bring in psychiatrists who have very specialist knowledge of medication, but actually that's very rare. Mostly in England, the family doctors would be keen to be involved, and that's the way we do it.
Good. I think it may be time for one last question. This participant he asked, I really appreciate what IAPT has achieved, which will play a good model in other countries to provide evidence effectiveness and cost effectiveness of treatment for common mental disorder. May I know if data in the IAPT program is open access or not? Is it possible for researchers from other countries to get access to the IAPT data to learn more experience from the IAPT? I guess it is from a health researcher.
Yes. So can I screen share for a moment?
Yeah, please.
So let me just lose this presentation and let me go on the internet. Yeah. Okay, so we have a government agency called NHS Digital, which publishes reports on IAPT every month, and also detailed reports once a year. And if you were to Google NHS Digital IAPT annual reports, which is what I'm going to do now, you should, yes, here we go. So, yeah. So here you see the web page, and you see reports on the IAPT services for each year. The latest report is for 21-22 financial year. If you click on that, you'll see some headline figures, how many people were seen in the services. And then you see that figure I gave us a bit over 660,000 people. It's 664,087 as it happens. It's recovery rates. If you click on this thing, annual interactive dashboard, you can see quite a lot of data on the outcomes of different, for the country as a whole, and by different services. And you can also look at them in different variables. So here it says select a variable. If I click on that, I can, because this is very relevant to JoyAge, of course, look at the outcomes by age.
Yes.
And I showed you a slide, didn't I, about the outcomes by age. I did that slide last night, and it's from this data source. So you can see here's the different age groups, and you can see the recovery rates with them, the best recovery rates in the older people, as you see there, 61%, 63%. So that's available to anyone, anywhere in the world.
Okay.
So you can look at that. You can also, you'll find, download what we call CSV files, which are raw data files, which can be opened in Excel, and you can study those. It's not individual patient data that you're seeing. It's average data for different IAPT services. So we don't at the moment publish individual patient data for researchers. I'm hoping that in time we will get to a point where we will produce anonymized individual patient data that researchers throughout the world can look at.
I think that will be wonderful. Yeah.
Yes, but I should say that the Lancet paper that I showed you earlier on, which looked at the characteristics of services associated with good or bad outcomes, that paper was done entirely with publicly accessible data. So anyone in the world could have written that paper.
Okay, wonderful.
I just went onto a public website and used the data.
Okay, Professor Kat, thank you so much. I know you have another important meeting coming up with the minister, in the UK. So I just want to, on behalf of the project team, I want to say thank you for sharing with us the insights. We heard a lot about the IAPT. We read the paper. We had really, I think this is really good information for us to digest and to kind of start planning the next phase for the JoyAge, as well as potentially, expanding, the JoyAge to non-elderly group. I think because it is much needed, particularly when you talk about increase in productivities, right? I think that is really for the group of people that we should pay more attention to. Let me now pass the microphone back to Eric, our MC. I think he will make the final announcement, on behalf of the project team.
Thank you.
Thanks a lot for your sharing and responding, Professor Clark and Professor Leung. Also, thank you everyone for your ideas and questions.
Bye-bye. Nice to see you all.
Bye-bye.
This is the end of our Day 1 event. Don't forget to follow us on Twitter, JoyAge, to learn more about our research.